Hello and welcome everybody. Thank you for joining us tonight for this webinar, which is hosted by Legs Matter, and it's taken over by the Society of Vascular Nurses, the SVN. Tonight our takeover is called the Peripheral Arterial Disease Myths and Management Take 2. So this is a follow-on session from our previous SVN takeover in September, when peripheral arterial disease was discussed, and it was so well received, and there were so many questions and comments that we thought we would do a follow-on session because they didn't have time to go through everything at that time. We'll mainly be focusing on chronic limb-threatened ischemia tonight, looking at how it can be recognised, how to assess for it, and when to refer to your local vascular teams. So I'm Nadine, I'm a vascular nurse specialist from Bedfordshire. I work at Bedford Hospital, which is the arterial hub for Bedford, Luton, Milton Keynes, if you know the area. The majority of my role is helping patients through the pathway from when they come in with critical limb-threatened ischemia, their inpatient stay, and then following them on discharge. I work closely with the diabetic foot teams in our local area, so that's where many of our patients present with CLTI. So yeah, a lot of what I do is with these patients. I am also on the SVN committee. I've been with the committee for the last year. I'm currently the Vascular Matters editor for those of you that are part of the Society of Vascular Nurses. So I'm pleased to say I'm joined with two of my amazing SVN colleagues tonight, Ben and Melissa, who I will let introduce themselves. Melissa?
Okay, thanks Nadine. Hi everybody, welcome. I'm Melissa. I'm an advanced clinical practitioner at Lancashire Teaching Hospital Trust, which is in the northwest of England. We are a large regional centre serving a population of around just over 1.5 million, spanning quite a large geographical area, and we have areas of significant socio-economic disadvantage. I'm actually based at the regional centre at the Royal Preston Hospital, and we cover 5 other hospital sites. I've got a special interest in chronic limb-threatening ischemia, frailty and diabetic foot disease. And I've been lucky enough to be part of the SVN committee now for the last 12 months. Over to Ben.
Hi, I'm Ben Cooper. I work in Aberdeen Royal Infirmary as a nurse consultant. I've worked in vascular for just under 15 years. We've got a slightly smaller population, so we cover about 500,000 people, but it's quite a large geographical area which stretches all the way up to Orkney and Shetland. Quite a lot of venous work over the years, but actually I work right across both work streams, arterial and venous, and I run the arterial hot clinics in NHS Grampian as well. So hi.
Brilliant, thank you both. So as I said, this is a follow-on session from the previous SVN takeover. So there are a list of questions and comments that came up from that session, which we will talk about through our discussion, but we are live. Do you want to be in? If so you have any questions, then feel free to add them to the chat or the questions box. And as we go through our discussion tonight, we'll try to bring them into our conversation. It is informal, so please feel free just to ask us anything that you think might help you. So yeah, so to begin with and to set the subject, I guess, let's briefly explain about the patient group that we're talking about. So what is chronic limb-threatened ischemia? Melissa, do you want to do that one?
I will take that one. Okay, so chronic limb-threatening ischemia, or CLTI, is an advanced stage of peripheral arterial disease. So if we just have a quick recap, when we're talking about peripheral arterial disease, it's atherosclerotic disease. So it's fatty plaques that build up within the inside of the arteries, which narrow down the arteries, restricting the blood flow. So if you think of it as a spectrum, you've got on one side of it are patients with peripheral arterial disease that have no symptoms, so they're asymptomatic, and that we think is quite a large percentage of patients. That progresses through to intermittent claudication, so mild, moderate, severe. And then on the other side of this, we've got the chronic limb-threatening ischemia. The definition is the presence of peripheral arterial disease in combination with ischemic rest pain, ulceration or gangrene for a duration of more than 2 weeks. And it's actually associated with a really high risk of amputation, increased mortality and morbidity, and impaired quality of life. The mortality rate for patients diagnosed with CLTI at 5 years is up to 50%. with a high percentage of patients having major amputation. And I think I'd argue that, and I don't know whether any of you feel the same, that I don't think it's seen quite as dangerous or severe as someone that comes in with an MI or someone that comes in with a stroke.
Yeah.
So I think it's really under acknowledged as a disease. So that's what I would say is CLTI. Anyone got anything to add?
Yeah.
No, but I think you're totally right. I think it's underappreciated in its severity, basically. Yeah.
Yeah. So how would you recognize a patient with CLTI? Who wants to take that?
Can I take that one, Ben?
Yeah, so I guess CLTI and arterial disease is typified by certain symptoms that patients can suffer from. And I think in the early stages, it can kind of manifest as, calf pain and claudication at the peripheral arterial disease stage. But as it progresses towards that chronic limb-threatening stage, sort of the typical things that we talk about are rest pain, whether that's intermittent or nocturnal, just at night time, or if it's unremitting and unresponsive to painkillers. And tissue loss as well typifies that more acute stage where we have tissue death because of the lack of arterial blood reaching the extremities. And that can be, described as wet gangrene, dry gangrene, various kind of wound types. So tissue loss and rest pain tend to be the big hitters that we talk about in that stage.
And that rest pain, it can be really unremitting. It's like it's really severe. It's really, when you see it, you really see how much the patients are suffering. And they often complain that they can't get comfortable. They wake up at night because the pain's waking them up and they want to hang their leg down to just get a bit of relief. So yeah, they really are struggling often with these patients.
Yeah, the worry as well. I know when patients come to our hot clinic, they may have been sat in a chair, sleeping in a chair on hanging legs off the sofa for weeks. And because they're sitting, they're not really moving about. They're also at risk of pressure sores as well. So that's something that sometimes isn't quite thought about as much. We'll focus on the leg where actually the patient comes in and they've got stage 2, 3, grade pressure sores as well.
Yeah, it's got a massive impact on quality of life and just progressively worsens as that disease progress, gets worse over time.
Yeah. And these patients, when you see, they've often got some risk factors and background behind, which would often set the scene of why they're presenting in this way. So maybe they've got a cardiovascular history, maybe they've had previous vascular interventions, high blood pressure, high cholesterol, lifelong smokers, diabetic, family history, maybe their mother or their father had an amputation. They often have a bit of a background which leads them to this point. So that often helps when you're assessing or recognizing a patient when you think they've got chronic limb-threatened ischemia.
Absolutely.
Sorry, we often say critical limb-threatened ischemia, but we're moving towards chronic limb. But because we've all said it for so long, it sometimes slips off the tongue. It's critical, but we mean chronic limb-threatened ischemia.
Yeah, I think we've talked about this, haven't we? After
Yeah.
saying it one way, it can be very difficult, to change to chronic limb-threatening ischemia. But I think that was the feeling it's quite an outdated term now, and actually chronic limb-threatening ischemia encompasses a broad range of patients now, whereas before things like our diabetic patients, there'd be a different set of criteria originally for them before they realised that diabetes was one of the big risk factors for peripheral arterial disease. But it does take some getting used to.
Mm.
Yeah, and the critical part always jumps out at me as kind of flagging how urgent it is, because it really is, a critical stage in that disease progress for people where limb loss is a real risk, and so that always jumps at me when I say critical. But I must try harder to move to chronic.
Mm-hmm.
I've got a question. So we were talking about rest pain. I get a lot of patients, and I'm sure you do as well, where they get referred because they've got rest pain, but because they've got pain in the calf at night time, and they're referring the patient because they think that that's rest pain. Is that rest pain? Is that what we typically see as ischemic rest pain?
Probably not. CLTI pain normally presents itself most in the foot, so it's the most distal part that starts to experience the pain. So typically it's patients that are complaining of pain in the foot rather than in the calf at night. That's what you said, isn't it? At night. So if they're getting woken up at night, yeah, I wouldn't think it's the calf pain being the CLTI, if that makes sense. Perhaps they've got an ulcer or something else causing the pain, which obviously they might have a degree of arterial disease, but CLTI normally presents in the foot.
Yeah, no, I agree. And I would say there could be a MSK reason. Some patients with kidney failure can get some calf pains, nerve damage, mineral defects as well. So there's lots of sort of other reasons for it.
Yeah.
Sorry, Ben.
Yeah, I think you're completely right. Yeah, the typical presentation is for critical for chronic limb-threatening ischemia pain to be felt in the foot. But I think it's worth saying as well that how patients report where they feel things and what their memory is of it can be really tricky in assessment as well. And it can be difficult to pin that down, and sometimes you get deferred pain and people, when they have claudication, feel it in their calves when they're walking, and sometimes they associate that when they get rest pain as well. So it's a really difficult assessment sometimes.
It is, absolutely.
Yeah. So staying on when I mentioned about having an ulcer, but if my patient has an ulcer on the leg, could that be CLTI? What do you think?
That one?
It's an option. It could be. It's certainly something that is worth thinking about in that assessment process. But I always think that assessment is a global picture of the patient. So one thing alone is never really enough to convince of a diagnosis or what should be done. So I think taking a history and considering that wound alongside symptoms, test results, and a good history will paint a picture for you that can lead you down that road in a better way than just thinking wound on its own or foot pain on its own. Yeah, I think these investigations and tests need to be considered as a global picture.
Yeah, I'd agree. I mean, obviously, we know that with CLTI, it mostly presents on the foot, but you have got those mixed etiology ulcers that can be really tricky to manage as well.
Yeah.
Definitely. There are lots of clinical features of wounds, even without investigations or imaging, just the description, looking at a wound, where it is, how it looks, how it presents, whether it's punched out, what the edges are like. So just wound care alone you can start to get a picture of what this might be. And what Melissa said is absolutely true, that quite often arterial wounds we tend to see very distally from the toes up onto the foot, whereas venous wounds tend to predominantly be in that gaiter area between the knee and the ankle. But again, mixed ulcer disease, every patient's different. We see different wounds in different places. So big assessments are important.
Yeah. So staying on that kind of line, so if we were doing an ABPI because the patient had an ulcer, if the ABPI came up as being 1.4, would that indicate CLTI?
I'll take that one. No, it indicates that the patient's got calcified vessels, which means that it's difficult to compress there, but it may not be flow limiting. So if you can't compress at the ankle, then I mean, I don't know about you, but I prefer toe pressures over ABPIs now for our patients. Anyway, I tend to go for toe pressures, so you're not less likely to get a calcification of the small digits as you are doing an ankle pressure there. So yeah, so for me, I'd be saying it's just showing them it's a calcified vessel.
Mm-hmm.
Interesting, just having just spoken about, signs and symptoms and how patients present at nighttime things. A couple of questions popped up in the Q&A. One person's asking, if a patient has had cramp in the legs at nighttime, does this indicate peripheral arterial disease? What are your thoughts on that? So that's kind of a similar question, but worded in a different way. Same feeling, or?
Same feeling. I mean, you're going to look at your full assessment anyway. You're going to assess your patient. You're taking that history. I think, like we said before, a lot of the time, cramping in the legs at night can have all different sort of symptoms. And sometimes it's idiopathic, so we don't really know why it happens. But you're going to take that, and just not in isolation, like you were saying before, Ben, it's part of that whole assessment of the patient. Because, like you say, some patients will describe things differently, but it's not a typical. I don't know if you.
It's not typical of it. And again, similar, just to get through a few questions, lots of clients complain of pain in the toes or toe at nighttime, but during the day they're not as aware of it. Is this a red flag along with other issues? So I guess, things that are occurring at nighttime, but less so in daytime.
Yeah. Do you want to take that, Nadine?
Well, potentially, I'm assuming maybe they are sitting with their legs dependent in the day, so that's impacting it coming across as being worse at night because they're trying to sleep in bed, they're trying to sleep with their legs elevated, and then through the day they're sitting back in the chair. So that's why I would say it's particularly more noticeable at night time, and then the patient might get woken up by the pain, and they want to hang the leg down. So potentially that could be the reason why. Is my thoughts.
So often it's gravity. So when you're sat with your legs dependent, gravity's helping to pull that blood and oxygen and nutrients down. And then when the patient goes to bed at night, they get the legs up in bed and gravity's not helping to bring that blood and oxygen down. And usually, even if you have some peripheral arterial disease, it's still enough to manage with your legs up. But if you've got chronic limb-threatening ischemia, you've got severe disease in the arteries, and suddenly that lack of blood and oxygen is just too much, and the patients get a pain in the feet and the toes, and they have to dangle the leg out of bed. And although the pain doesn't completely go away, it certainly eases it. So it's definitely a red flag for CLTI.
Yeah.
Absolutely. And I guess as well, somebody else asks, we're saying that there might be other things going on. Multi-comorbid patients might not be arterial disease. That's the root of the symptoms we're talking about. What are the other things that people should consider, for this cramping pain at nighttime or claudication type pain? And I guess the first thing that comes to mind is sort of spinal problems. So again, you were saying about MSK, spinal stenosis in particular. Can cause similar pains down the legs. And so I guess it's about history taken and evaluation at that stage.
Yeah, and even things like with our elderly population, they get shortening of the tendons, so that can also cause calf cramping at night time as well. So there's a myriad of other reasons why.
Yeah. So one of the questions from the last session was just looking at who is at risk of CLTI. I think we might have covered it a little bit already, but these patients can present quite young, actually, can't they? They do have a background of atherosclerotic disease often. Maybe they've had an MI young or they're diabetic quite young. So yeah, we are seeing quite young patients.
Yeah, I would agree. I tend to, when I'm explaining to patients or to anyone I'm teaching, is when I'm looking at risk factors, I'm looking at the non-modifiable and the modifiable risks. So the things we can't do anything about and the things that we can. So your non-modifiable are your age. And we know that as a rule, peripheral arterial diseases are progressive disease as you get older. However, we are now seeing a younger cohort of patients, quite worryingly, and also family history. And I tend to joke and say I can't choose some of my family, and I definitely wouldn't. So you can't choose your DNA. So those are the things we can't do anything about. But then we're looking at the things that we can. And yeah, smoking, one of the most powerful predictors of peripheral arterial disease. But I was reading somewhere the other day that diabetes is actually fast approaching to become one of the more significant arterial risk factors. I guess we're getting an increase in population of diabetes, and hopefully more people are now stopping smoking. And then, yeah, hypertension and dyslipidemia. So those are the sort of main risk factors that we're looking at.
Yeah. Smoking is a big part of my role, actually, trying to help patients to stop. But I have been thinking, actually, maybe I could do more. When they're inpatients, we can easily start nicotine replacement, talk to these patients about stopping, and trying to give them some counselling and referring them to the relevant teams. But from my perspective, I think maybe I could do more for the patients who are outpatients. And someone said something last week that made me think about how in clinic it would be better if we could maybe start nicotine replacement from clinic, which we don't currently do in our area. But smoking has such a big impact for our patients that I'm thinking, well, maybe that's something that we could do more where I work.
Absolutely. What's it like where you work, Ben?
Yeah, we refer for smoking cessation services from clinic. And we've got a really good rate of stopping smoking through the hospital-based smoking cessation, about 80%, in fact, which is really high. But I think it's really interesting because we think of vascular, and over time, things like abdominal aortic aneurysms, they found are less being discovered in screening than they expected. And they think that that's because of, less people smoking. But at the same time, when we look at lower limb critical arterial disease, we've all done clinics and we know how many patients come through the door that are still smoking, who find it difficult to smoke. So it's different, different statistics, and how what we see in practice is really hard. Somebody else has popped in the questions just whilst we're speaking about, again, risk factors and smoking in clinics. They've said BMI or lack of cardiovascular exercise question mark. Is that an impact as well? And I guess what springs to mind with the BMI and sort of obesity and being overweight is that potentially sedentary lifestyle. And one of the things to speak about is that one of the big things we do is encourage people to walk as much as they can to develop that collateralized circulation and try and bring the blood flow down the leg. And that can be quite hard in various patient groups, whether they're age-related difficulties, smoking, comorbidities like COPD, or things like obesity and lack of mobility. So they're definitely a complex patient group to manage. Lots of things to take into consideration, whether it's polypharmacy, comorbidities, quite a complex patient group to manage in clinic, but also to assess because of these things.
Absolutely. There's another question in the Q&A from Jane. It says, she's saying, do you think it would be helpful to give patients a little card as a warning for the symptoms of worsening CLTI, and what to do if things get worse?
Yeah, I think that there are lots of other, medical specialties or medical conditions that have embraced that kind of patient education with red flag warnings. And I think in vascular, it would be really helpful at every stage, at that peripheral arterial disease, claudication stage, right through to the early stages of more advanced disease, so that people can have early access to services by flagging up to us quicker.
Yeah. Yeah, because once a patient is diagnosed with peripheral arterial disease, it's not going to go away. They might be stable at that time, but at any time that could progress into CLTI. So for the patient to be aware of that and to know the risks and to know that it's actually a critical time, it's important that they are aware and that they're seen by a professional that can refer them back to the vascular teams.
Yeah.
Yeah.
Another couple of Q&As. So Annie's asking, how do we think vaping will affect patients in years to come? Will we see the same effects? That's a really good question.
I mean, I don't know the answer to that, but I mean, it still has some nicotine in it, doesn't it, most of the time? And often patients use vaping to stop smoking, but then they get addicted to vaping. So it's difficult because obviously these patients probably smoked for 60 years and and maybe that, you know, it's just hard for them to stop. But there is help on hand, and there are other options. But yeah, vaping wise, I don't know. I guess we'll wait and see what the research shows in the future. But wouldn't recommend it
I'm not sure.
personally.
Yeah, we don't know, do we?
No.
It's not been long enough in the research to see what the effects are long term. But it's a tough one because you really want people to desperately stop smoking when you see them with, you know, particularly we're talking about that middle to advanced stage of arterial disease through CLTI. And you know, getting them to stop can be really hard. And sometimes any replacement therapy feels like it's worth a try.
Yeah.
If it's on that journey to completely stopping. So it's a tough one.
Yeah.
Absolutely.
It's about finding the right nicotine replacement for the patient, isn't it? The one that's going to work for them, and distraction and support.
But the impact is huge, you know, and it's hard for patients because quite often patients may come in their 60s or 70s having smoked for 40 years or 50 years. It's difficult for them to understand sometimes that stopping even at that stage is going to be beneficial.
Yeah.
And I think the important part for them to be communicated with them is that if we do intervene, whether that's through a minimally invasive angioplasty or an open bypass, that the longevity of that procedure, how well it does and how well they do, may hinge upon them stopping smoking beyond that point. So
Yeah.
I think working with patients is worthwhile at that stage.
Yeah. And it affects, you might have just said this, but affects the if they have an intervention, is that what you just if they have an intervention, then it's more likely to fail, it's more likely to block. And so that's why we really need to focus. But I agree, I see this time and time again, patients think, oh, it's too late now, I've been smoking all my life. There's no point trying to stop now. But we're trying to prevent amputations, trying to prevent further problems, keep a functional limb. Yeah.
Yeah, and so, you know, optimizing patients, I guess that leads on to, and best medical management is important. It's not something that would stop us seeing patients if they weren't on best medical management, but in terms of, you know, optimizing people going forward, even at that middle to late stage, it's worthwhile looking at best medical therapy alongside lifestyle changes like stopping smoking, losing weight, walking more.
So with the walking more, there's a question in the Q&A that's saying, we tell people to walk as much as they should, as much as they can, but should we be more specific with our recommendations? So
what do you tell patients?
So, I mean, general consensus is walking about 30 minutes, 3 to 5 times a week until the onset of the pain, stop, rest, and then go on again. I know where I am, we have a little walking exercise sort of chart that the patient can write and fill in, just so they can see if they're going any further distance. And normally, if they can see that they're going a bit further, it just spurs them on to go a little bit further. I think it's a difficult one. Obviously, exercise programs are in the NICE guidance, but we also know that there's lots of, you know, most areas don't have a supervised exercise program. Where we are, we have links with heartbeat. So for the cardiovascular rehab, they actually see our claudicants. But interestingly, the uptake isn't great, which we're looking into at the moment to see, well, we've got this supervised exercise from the heartbeat team, and the uptake still isn't there. So it tends to be those that are really, really enthused who are asking, what can I do? How much walking shall I do? Are the ones that want to take that on. So yeah, it's a bit of a challenge.
Yeah. Before COVID, we used to run a supervised exercise program here. Since COVID, the funding stopped. But beforehand, when we did run it, we used to see some really good effects from getting the patients together, working together, good support group network, and that spurred them all on to try and do a bit more, trying to walk. We met once a week, and then we encouraged them to go for walks 3 times a week as well. That does really work. So if you have that in your local area, that's brilliant. Now we we do the same as you, really. We encourage patients to walk ideally 3 to 5 times a week for half an hour to an hour, depending what they're able to do, trying to walk through the pain as much as possible. And then when they really have to stop, then stop, let the pain subside and then go again. Some patients have some really good results from that. And obviously that's what we're aiming to do. So avoiding revascularization and trying to build their own health and well-being, their arterial disease by themselves. So that's brilliant. Other patients, they are heading down to the revascularization route. But yeah, exercise is really a good thing, and we really encourage that. Yeah.
We've never had a supervised exercise program. We just haven't been able to fund it, staff it, put it in place. But what we did have some success with was kind of like a semi-supervised program. So we had a psychologist who actually came and worked with patients around, because there is typically been bad engagement with exercise programs. And we wanted to kind of understand why and see what we could do from a motivational point of view. And we also gave them all pedometers, like smartwatch type things.
Yeah.
And checked in with them. I can't remember now if it was weekly or monthly, but we encouraged them to not really increase their walking to begin with, just to record what they were able to do by steps a day. And then week on week to kind of diarise that and add in an extra X amount of steps until they were building things up over time. And we had some really good results with patients with that. And we found that there were a lot of psychological reasons why people couldn't stop smoking, why people were struggling to get out of the house. And actually, when they had that kind of motivational input, they were able to engage with it and do a bit more. So it's quite interesting.
Yeah, I bet that was. Yeah, that's good.
There's been a few more questions in to jog us on. An interesting one about cannabis users, actually. So we're finding that a lot of younger patients are cannabis users. Do you think the use of cannabis rising is having an impact on younger patients being affected? And is this something you speak to your patients about? I definitely speak to my patients about it in quite an open, honest way, because it's quite a prevalent thing for people to be doing. And I've got to admit that, yes, I've noticed that cannabis users tend to present at a younger age. What do you guys think?
Yeah, I feel the same, and we do see the same as well. And absolutely, it's having that open, honest sort of communication. When you're taking your history and you're talking about medication, it's not just prescribed medications. It's are you taking anything over the counter, or are you taking any illicit drugs, anything that's non-prescribed as well? Most of my patients are quite open and honest about it, to be quite honest. But yeah, we are seeing a younger cohort of patients, and that probably correlates with that.
Yeah, I'd agree with that. And quite often what I find is that we're trying to encourage the patient to stop smoking, and they say, oh, but I smoke cannabis, so I'm still going to need to smoke the cannabis. So that can get tricky then.
Yeah. Or they don't feel it's the same as smoking a cigarette.
Yeah.
They feel it's completely different.
And actually, it might be worse.
Yeah.
Definitely, I had a run of patients for a while that were kind of in their late 30s, early 40s, who had quite significant popliteal disease, who were cannabis users. Quite interesting to see them present at that age. But yeah, we do have open conversations with them. And I think once they realise that you're not going to be judgmental and have a proper conversation with them, that it opens the field more to make some changes.
Yeah. Yeah, I'd agree.
Thinking about that walking exercise and classes that you guys were talking about, somebody has asked, cardiovascular rehab. So I guess, post cardiac intervention, post CABG, post triple bypass, has always had quite a good engagement rate with patients in terms of exercise classes. Why has that been successful, and peripheral arterial disease exercise not so successful?
I think this comes back to what I said at the beginning, which is that people don't seem to perceive peripheral arterial disease is as significant a risk factor as cardiovascular or as a stroke. If someone goes into A&E because they're having a heart attack, they know, oh my gosh, I might die. If they go and have a stroke, oh my gosh, but they get a pain in the toe at rest or a little bit of a scab on the foot, and it's such a surprise to them to, you know, see the extent of it. So I do think that it's just how the patients, you know, perceive it. And I don't think we shout it enough, to be honest. You hear about,
Yeah.
you know, heart attack, you see the adverts about stroke and you see the adverts about, you know, if you're having a heart attack. But what do we see for peripheral arterial disease of the lower limbs?
Yeah.
Nothing really.
And potentially it's because the services aren't there as well. I mean, like I said before, we don't have a supervised exercise program here now. And I remember from when we did do it, yeah, the motivation and the uptake, you know, patients would quite often decline. But now we can't even test that because we haven't got the service. Whereas I know cardiac rehab, they do. So maybe it's to do with what services are offered as well.
So there's another question here. This one says, patients with claudication and mild to moderate peripheral arterial disease with no wound, do you often refer onwards to vascular or more conservative management, managing their cardiovascular risk factors?
I mean,
I need to read that twice. Yeah, go for it.
I would still refer because they are having trouble with peripheral arterial disease, and then it might help get them signposted to some support and, you know, the network that they need. By all means, in the primary setting, you know, in the community, you could start the smoking cessation, encouraging the patient to exercise. You can mention all these things, but I think as well, just if they're referred to vascular and they're seen, and they might be able to get some further support. So yeah, I would still say refer.
I think it's a really patient by patient specific thing. It's really hard. We can have patients, I mean, I've met patients in clinic who are still working in their 70s or 80s, depending on what they do, but certainly not unusual to have a 70-year-old still working at the moment. And if their occupation and livelihood is threatened by the fact that they can't walk more than 50 meters or 100 meters, then I think that's got to be taken into consideration seriously. And I think onward referral is worthwhile. And again, it really depends on the impact to their life. If somebody lives very remote and rural, they're on their own and they can't walk to the shop, it can have a massive impact. Whereas if somebody has poor mobility for other reasons and that's their only symptom, but they are very supported, it might not be having the same impact. So it really depends. It's hard.
Yeah, I agree. It's definitely patient by patient basis. And for those mild, moderate claudicants, who you have got on best medical therapy and you're going through the lifestyle factors, it's about you can manage them in the community and refer in if you feel that they're deteriorating. I guess every centre is going to be a little bit different as to, you know, who they'll sort of accept in terms of claudicants. We get everybody referred to ours, and we'll see them. We'll do a full vascular assessment, pre and post treadmill testing, lifestyle advice, possibly follow them up once. We'll refer them into our exercise program, the rehab exercise. And then if they're stable, we discharge them, but we're happy to see them back if they deteriorate.
Yeah.
I'm sure the old statistic was about 20% of patients with that earlier stage pad and claudication are likely to progress, you know, down towards that critical limb. And so there's no crystal ball. That means 80% of the claudicants might not, you know, go down that road. So optimization at that stage is definitely, you know, worthwhile for the whole group. Whether that's lifestyle or best medical management, definitely.
Yeah.
So when you get these patients, how are you assessing for CLTI? So that patient comes into the community setting or they come to see you in clinic. What is it that you're doing to assess them?
Nadine?
Well, I think it's like we said at the beginning, really. So it would start from history taking, seeing what the background is, seeing how the patient is presenting regarding their symptoms, what are they experiencing, what's their complaint. Assessment wise, obviously you're going to look at their limbs, try and palpate pulses. If you can't, you could use other systems. So you could do an ABPI, you could do a toe pressure. But I guess the message is really not to be dependent on those numbers, not to fixate on that pressure or that number, but actually look at the patient as a whole, and think about the whole picture about how is that patient presenting. If that makes sense.
So if you've got a patient whose ABPI is less than 0.6 or the toe pressure is less than 30, do you refer would you expect all patients to be referred in?
Not necessarily, no. I think it's a test, it's a useful test, but the term I like to use is global picture. You need that global picture of symptoms, test results, patient history, discussion, talking to your patient, working out how it's affecting them, and putting that all together is the only real way to make the right decision, I think. An ABPI on its own is just a test result without an associated symptom. And, if somebody's asymptomatic, no, you probably wouldn't want to progress them down a pathway of imaging and consideration and surgery potentially, which, let's face it, can have a risk of harm
Yeah.
at the end of the day. And so surgical intervention's not for everybody. Even symptomatic patients, in fact, surgery is not for everybody. And I think balancing the benefit to risk at the various stages is a tricky but important part of the judgment that we have to employ.
Yeah. So when would you consider referring to vascular teams if you were concerned about CLTI?
It would be nice to have a referral that contained as much information as possible, wouldn't it, really?
Yeah.
So that's half the battle. So yes, an ABPI result is useful in a referral because it tells you a bit about what direction things are going in. But you want to hear in a referral about what we've just spoken about, so symptoms. So if a patient has progressed from claudication to rest pain, whether that's nocturnal intermittent rest pain or whether that's, unremitting rest pain all the time, that's definitely an indication alongside your ABPI or other test results that this patient likely needs a referral to vascular.
Yeah.
Similarly, a low ABPI and tissue loss, hand in hand.
And I guess the key thing is really those patients that have CLTI, the time is, I think I said this before, time is critical. So actually we have timeframes that we're trying to stick to. I don't know if everyone's aware of this, but the Vascular Society set a guideline where those patients with CLTI who are really at risk of, so they've got severe rest pain, tissue loss, then we try to intervene for those patients within 5 days, which actually doesn't give us much time at all. So we want the patients to present as early as possible so we can assess, get the imaging done, and a decision can be made about what intervention can be done for those patients, because 5 days, it's hard to achieve, but by the patient presenting earlier, it gives a bit of a chance. I guess I should also add that the patients at home that are stable, we're still trying to aim for 14 days. So there's still quite a short time frame. How do you manage that in your areas?
In our area, it can be a little hit and miss, but that is because, number one, yes, refer those patients in with CLTI, those red flag patients, refer them in as soon as possible. However, we may not necessarily treat that patient. It depends on the patient. So we tend to if we're looking at the patient, we'll look at the whole patient, because they are a comorbid group. But we do operate on these comorbid patients. It's just that sometimes they're so complex that we might need to look at optimizing any medical management. So if there's if they've got COPD, we might need to get respiratory involved to optimize. If they've got any cardiac issues or heart failure issues, we might need to involve the heart failure specialist team, anything to try and make it easier on that patient if they're going on to have any sort of intervention. And really we're looking at, so we tend to consider how much tissue loss there is, how difficult or easy it is to revascularize that patient, and how fit is the patient, what are the risks and benefits of offering them the surgery. And sometimes the best thing to do is to not do anything, and you're managing the symptoms, so you're keeping any wounds as dry as possible and free from infection as best as possible, and pain relief. But really, if you refer those patients in, that's when we can do that assessment and really sort of move that forward. We try and stick to those targets as best we can, but it can be difficult.
Yeah.
Do you guys use Wi-Fi scoring in your assessments for these sort of, arterial and critical limb patients?
So in my area, we're redesigning really our hot clinic urgent pathway for our CLTI patients. So as part of the redesign, we do more nurse-led standardization of it. So we will be using Wi-Fi more frequently than what we do currently, but it's something we're aiming to use more of, yeah.
So anyone that's not really familiar with the Wi-Fi system, it's a classification, which is it's validated tool designed to assist the stratification of amputation risks and benefits of revascularization in patients with threatened limbs. So the W stands for wound, and that's graded 0 to 3. So 0 being no wound and no gangrene, all the way through to 3 being extensive, sort of deep wound extending on to the bone or involving the forefoot or the midfoot and the calcaneum. And then the I stands for ischemia. And again, they're all graded 0 to 3. So 0 would be your ABPI equal or above 0.8, or your absolute pressure above 100 millimeters of mercury, or your toe pressure above 60 millimeters of mercury, all the way down to 3, which be your ABPI less than 0.39, your absolute pressure less than 50, and your toe pressure less than 30 millimeters of mercury. And then the FI stands for your foot infection. So from 0, no infection, to 3, which is, well, 2 would be like your local infection, you involving the deeper structures with more than 2 centimeters of erythema around the wound. And 3 would be that plus being the patient systemically unwell as well. So they'll have a temperature, high heart rate, increased resps. If you've done bloods, the white cells, the inflammatory markers will be elevated. So when you score your patient on that, and then there's a calculator, so you can go on the app on the ESVS or SVS have got an app. So then the calculator will stage that patient then 1 to 4, with 1 giving you a 1-year major amputation risk of 2 to 3%, and revascularization benefit score of being low or very low, sorry, all the way up to, if you're scoring a 4, then that amputation risk is 50% within a year, and the revascularization benefits are really high. So it's another tool to help us try and determine, risk of amputation and benefits of any intervention.
I posted a link to, I think it's the original research article that kind of speaks about Wi-Fi scoring and it being a validated tool. And I think it's interesting to look at that because it really pinpoints that it's a tool specifically for this patient group, for arterial disease. And what it was designed to do was help you work out what the risk of amputation is, alongside potentially what the benefit of revascularization is. And I think because it's such a specific tool for this conversation, it's great and it's something we should look at, as long as we don't try and apply it to other areas of vascular surgery like venous patients, where actually things are quite different. We talk about compression, we talk about how the wounds have gotten there, and I'm not sure that this really helps to do that. But for this patient group, it's worth reading and worth looking at.
Do you use it then, Ben, in your hot clinic?
Yeah, so when I started doing hot clinics, I didn't really know anything about Wi-Fi, I'm not going to lie to you. And it was only once we started looking at the guidance around hot clinics that I gathered this information that didn't mean much to me at the time. But then it helped me because retrospectively I looked at the decisions I'd made and it helped me kind of justify what I'd done. And going forward now, prospectively, we do use it to help work out that inpatient versus outpatient route. What's the risk of amputation? How severe is this? And if anything else, somebody's posted in the comments about the ESVS or the SBS Wi-Fi calculator, and Melissa, you mentioned it as well. But it actually just helps you organize your assessment and thoughts as well, because it breaks it down. How bad is this infection? Does this patient have gangrene? Where is that gangrene? Is it limited to the toes? Is it spreading up the foot? What does your ABPI indicate? And it'll tell you. And then it puts it all together and gives you a bit more of a risk stratification, I think, really. So yeah, it's a good tool, and I do use it more now day to day, prospectively.
Yeah, I agree. I really like this tool, and because it's it's for lower limb, it's for foot ulcers and encompasses diabetic. So we've not got the other classification tools like the Simbad or things like that. It's really good just to have that one tool that's really easy and straightforward to use, which is what we need. We don't need things to be complicated.
No.
I definitely don't need things.
Me neither.
But would that stop you? So would you expect if your patients out in the community being seen by the community teams, would you accept a referral without the patient having that toe pressure?
Absolutely. Yeah.
Yeah.
I think just if there was concerns of CLTI, like I said before, we don't need to have numbers. Just stating this patient has what seems to be rest pain, they have tissue loss, or either or, and I'm concerned about chronic limb threatening ischemia. For us, we would see the patient to be able to assess here in the vascular unit and then make a decision about what needs to be done. So absolutely, we wouldn't expect numbers. We wouldn't expect, we just want the bigger picture. And in fact, providing numbers, that's not what we want. We want the actual clinical signs, how the patient is presenting.
I would say the majority of referrals that I look at do not have an ABPI in them, and actually that vetting of that referral and us, agreeing to see the patient is based on that qualitative kind of quality of life stuff that the GPs write. I say GPs, anybody who sends in a patient, about how they're being affected, what their symptoms are, and the things that we've outlined in terms of wounds, gangrene, all these things.
Yeah, we don't want that referral to be delayed. If you're with the patient and you're doing that as part of that assessment, fantastic. I tend to find a lot of our referrals will have an ABPI or a toe pressure, depending on which area they are, which is great, but don't let that stop you. If you've got that patient and you think these are signs of chronic limb-threatening ischemia, if you're not sure, pick up the phone and speak to your friendly vascular specialist nurse or your on-call registrar. We're all happy to help and to advise in any way. So yeah, but don't let it stop you referring in.
No, and that discussion leads to learning and education and improved patient experiences, really. The more we talk to each other across specialties about this, the better that experience becomes for the patient and for us, I suppose, as clinicians as well.
Yeah.
Absolutely. So Annie's saying, not everyone has access to a TBPI kit. Do you think it is essential kit to have?
No. I don't think it's essential, I'll be honest with you. It depends who we're talking about and in what context. Do I think it's essential for every GP practice to be able to do TBIs? No. Should vascular specialist units be able to do TBPIs? Yes. And then there'll be all sorts of middle ground stuff that's hard to comment on. I think if you can learn to use these things and employ them as part of your toolkit, then great. But you shouldn't view it as just like what Melissa, just as Melissa has just said, it shouldn't restrict you from being able to assess and send people into specialist services.
Yeah.
And I guess in the same sort of area, another question that had been asked before was, is breast medical therapy vital for patients with CLTI?
No. Well, so the most important thing is referring to the vascular team. That patient needs to be seen urgently. the vascular service there, the vascular team there can decide about the best medical treatment, but really the priority is getting the patient seen by vascular. So actually the priority is referring to vascular by however your local system is.
I guess you can open that up a little bit and say, you know, should not being on best medical therapy for 3 months or however long stop you referring a patient? No, absolutely not. Is it essential to that patient to be on best medical therapy? Yes, it is. And starting them on it, you know, as quickly as is feasible, it is the preferred option, and that would be in primary care before they've even sent them in. But no, having a 6-month trial and see how it goes at the stage of critical ischemia is not the thing to do. Is that fair?
Yeah, but what would you
Yeah.
include in the best medical treatment? What are you thinking?
Melissa?
So it's your antiplatelets, of which for symptomatic patients, we're recommending clopidogrel. Although there is a bit of a bone of contention at the moment over clopidogrel, with some people being resistant to clopidogrel. For me, I'd just rather they were on an antiplatelet, you know, whether, because we get a lot of questions, oh, this patient can't take clopidogrel, and that's recommended, could they have aspirin? Absolutely, if they can't tolerate clopidogrel, they could have aspirin. Obviously, you've got to look at your bleeding risks and your risk benefits for any medication that you're taking, but an antiplatelet and your statin. So we're looking at high intensity statins, so your atorvastatin or your more moderate, which is your rosuvastatin. But again, as long as they're on a statin, I'm happy with that. We could add in ezetimibe, but we've got the newer statins, which I can never pronounce. I'm not that familiar with them as yet. You know, so yes, that's what I would class as your best medical therapy.
Yeah. Oh, we've got a few minutes left. Is there any other questions anyone would like to ask before we finish?
There's a really great point someone's made about communication, breaking down communication barriers. I can only endorse that, you know, cross-specialty communication and education working together. And then there's one that comes after asking, do you often put patients on, and I can never pronounce this.
Me neither.
Properly.
I'm glad you're reading it.
Naftalol for qualification. The answer is no, I don't often personally put them on that. Does anybody else customarily use that?
No, we tend to find that patients with claudication that are referred may have been started by the GP, and they might have been on it for ever and a day, and then they come to us and it's not had any benefits, and I'm like, well, stop it. It's not doing you, you know, it's not helping at all. But I'm sure some patients find a benefit. I don't tend to find many that do, that come to see me, but, you know, maybe not necessarily seeing all of those patients. Or it's not something that we'd routinely prescribe.
No, I mean, we occasionally, very occasionally do prescribe it, but that's more for patients that really do not want any intervention. It's just a last attempt to see if anything else would help, or just a short trial to see if it does at all, but we don't use it routinely, no.
And Jane's asking, what about aspirin and rivaroxaban? So if we're looking at the COMPASS trial.
This will have to be our last question because we are actually at 29 minutes past. The COMPASS trial, yeah, we do see that as well. Quite often we would use that after an intervention, I would say.
Yeah, we tend to use it after a complex intervention, or if a re-intervention, then they'll look at aspirin and rivaroxaban.
Yeah.
Yeah.
Well, I think
increasingly after. Yeah. Sorry, no.
Sorry. Well, I think that's about it, to be honest. Thank you so much for joining us tonight. I hope that you found our takeover interesting and helpful. And I hope that next time you're assessing a patient with peripheral arterial disease, chronic limb-threatened ischemia, that some of our conversation might help. I'd just like to say a big thank you to Legs Matter for hosting this session and for the Pink team behind the scenes, and to thank my brilliant colleagues, Ben and Melissa.